Questo DVD è mirato a spiegare una tecnica di latergetto, una tecnica che viene utilizzata nei casi di instabilità durante, antero-inferiore. Inizialmente la tecnica nasce quando esiste un blocco sulla testa dell'omero o sulla capitaligine. Sono lesioni.
The topic we will be discussing is traumatic antero-inferior shoulder instability. In traumatic antero-inferior instability, as can be seen in the film clip, there is a lesion, Bankard lesion, of the capsulo-legamentose complex in over 95% of the cases, and there may also be bone damage on the humeral head and glenoid. When the bone lesions involve both the humeral head and the glenoid at the same time, we refer to this as a bipolar bone loss lesion. The evolution of lesions of soft tissue has been covered in literature, so it is known that a Bankard lesion can evolve and that there are various kinds, ALPSA and HAGL. On the other hand, little is known of bone lesions following repeated dislocation episodes over time. In deciding whether to treat a patient with a classic arthroscopic repair of a Bankard lesion, that is, a capsulo-legamentous repair, or with a repair envisaging a bone support such as the Latarjet technique, it is necessary to consider the bone loss and the poor quality of the soft tissue. These are the decisive factors. To interpret the bone loss and manage to quantify it and understand its role in a possible surgical failure, it is necessary to clarify exactly what is meant by bipolar lesion. In recurrent dislocations, glenoid bone lesions are described in literature as being present in around 86% of cases, Hill-Sachs lesions in around 94% of cases, and bipolar lesions in 81%. Why is bone tissue important in glenohumeral stability? Bone tissue is particularly important in the mid-range, intermediate stability, in which joint stability is guaranteed by the negative intra-articular pressure and stability ratio, while at the extremes, end range, the stability is supported by the capsulo-legamentous complex. Now we'll take a look at glenoid defects and Hill-Sachs lesions. Glenoid defects may be of either the fragment type or the erosion type. The fragment type is usually present in cases where the capsule is strong and of good quality, whereas the erosion type seems to be present if the capsule is weak, where it will elongate and the glenoid rim will be compressed and eroded into a compression fracture. Other authors distinguish the fragment from the erosion type by the fact that the erosion type is not really an erosion caused by chronic fission, but is caused by the compression between the rim and the humeral head. We need to prove this in the future in any case. Our opinion is that in the etiopathogenesis of a fragment type versus an erosion type, a role may also be played by the lesion mechanism, probably in lesion mechanisms that occur in the abduction and external rotation. The strain of the capsule might create a tear lesion on the bone tissue of the glenoid. On the other hand, in dislocation mechanisms that occur in adduction, the humeral head would be compressed against the glenoid, since the ligaments in this position are loose, so an erosion fracture might be created on the antero-inferior part of the glenoid. How can a glenoid bone defect be identified or calculated? There are various techniques, and we will describe them from the surface area method to the PICO method and so on. On the other hand, Hill-Sachs lesions, which refer to a bone defect on the posterior surface of the humeral head, can be identified in X-rays, and were already described by Malgenia in 1955. Their incidence increases with the number of dislocations, being described in literature as being present in 65 to 67% of cases after a first episode, and in over 80% in recurrent cases. When we speak of Hill-Sachs lesions, we must keep in mind several parameters that serve to evaluate the importance of this type of lesion. One is the width, and another is the inclination angle with respect to the diaphysial axis and its medial lateral position on the posterior aspect of the humeral head. In any case, glenoid defects and humeral defects must be considered together. The first to make this consideration in 2000 was S. Burkhardt, who described Hill-Sachs lesions as either engaging or non-engaging. Non-engaging lesions are those which, in abduction and external rotation in narcosis, before repair of the Bankart lesion, do not engage in the antero-inferior part of the glenoid. On the other hand, engaging lesions are those which, in the same position in narcosis, before repair of the Bankart lesion, engage in an antero-inferior part of the glenoid, as can be seen in the film clip. In our opinion, as important as this situation is, it is far from a normal one. In fact, what we are interested in is knowing whether the Hill-Sachs lesions engages or doesn't engage after repair of a Bankart lesion. We think all Hill-Sachs lesions are engaging, in the sense that at least once the humeral head has suffered an antero-inferior dislocation from the glenoid and created a Hill-Sachs lesion, it is simply a matter of reproducing the degrees on the three levels where the lesion has formed and the amount of stress applied to the humeral head during the dislocation. In conclusion, in our experience, all Hill-Sachs lesions are potentially engaging lesions. The important question is, does it engage after Bankart repair? An interesting study by Kurokawa reports that after a Bankart lesion has been repaired, only 7% are allegedly Hill-Sachs non-engaging lesions. How can an engaging lesion be distinguished from a non-engaging lesion after a Bankart repair? It is impossible to assay the stability after the Bankart repair on the operating table because this would put the repair just completed in great jeopardy. At the same time, it would not reproduce a realistic situation because the neuromuscular and proprioceptive control apparatus would be absent and the shoulder relaxed by the aqueous solution. To better understand this concept, we need to refer to Itoi's Glenoid Track. Itoi describes the glenoid track as a contact zone of the glenoid on the humeral head with the arm at the end range of motion, and it measures exactly 83% of the glenoid width. In substance, the glenoid tract guarantees the bone stability in the position of abduction and external rotation, and measures exactly 83% of the width of the glenoid. GW is the glenoid width, and the 83% is the GT, which, positioned medially in the footprint of the cuff, is the glenoid tract. The position of the Hill-Sachs lesion on the humeral head becomes important, along with, in particular, its relationship with the glenoid tract. If the Hill-Sachs lesion is within the glenoid tract, as can be seen in these clips, and we repair the Bankart lesion that was created by the traumatic event, when the patient returns to his sports activity after 5 to 6 months, he will have an optimum anatomical situation because the capsulo-legamentose complex has been repaired and the glenoid tract, not completely disturbed by the Hill-Sachs lesion, guarantees bone stability. We have called these Hill-Sachs lesions on track. On the other hand, off-track lesions are the Hill-Sachs lesions which, probably depending on the lesion mechanism and number of dislocations located on the most medial aspect, completely disturb the glenoid tract. We have thus called these lesions off-track, and in these cases, if we were to perform the classic capsulo-legamentous repair operation arthroscopically using suture anchors, arthroscopic Bankart repair, when our athlete resumes his sports activity, we will have excessive stress on the repaired capsulo-legamentous complex because there is no humeral head bone to support. That is, there is an insufficient glenoid tract, which increases the probability of a surgical failure. Even more interesting is making an assessment together of the bone lesions on the humeral head aspect and glenoid. When there is a glenoid bone loss, the surface of the glenoid tract is clearly reduced. Imagining having this bone defect on the en face view with subtraction of the humeral head, we see how the new glenoid tract is smaller, since we've had to subtract the glenoid bone loss from the glenoid track. We'll now introduce the concept of on-track and off-track described in 2014 by these three authors. How to assess the bone loss and understand if the remaining bone can handle its stability role. Our example shows only humeral bone loss, but no glenoid bone loss. First step, CT scan of both shoulders and creation of an en face view of the glenoid. Second step, measurement of the greatest horizontal distance of the glenoid width on both shoulders, which in this case will be the same. It can be seen that in this image, AB is the diameter of the glenoid, and AC is 83% of AB and represents the glenoid tract. So we overlay the glenoid tract, which is 83% of AB, on a 3D reconstruction of the humeral head with rear view. We situate the glenoid tract immediately medial to the footprint of the cuff, and we make our assessment. If the Hill-Sachs is in the glenoid tract, we call it on track. If instead it is more medial, we call it off track. In the first case, we opt for an arthroscopic Bankart, while in the second case for a Latarjet procedure. How to assess an on-track, off-track Hill-Sachs in bipolar lesion? The next example is one of humeral bone loss and glenoid bone loss. First step, CT scan of both shoulders and creation of an en face view of the glenoid. Second step, measurement of the greatest horizontal distance of the glenoid width on both shoulders, which in this case will be different. AB is the diameter of the normal glenoid. CB is the glenoid bone loss. AB1 is the glenoid tract of AB, that is, of a normal glenoid. From AB1, we have to subtract CB, which is the bone loss, and thus we obtain the new glenoid tract, AL. We overlay on the same 3D CT scan the new glenoid tract, which will obviously be smaller, and we assess once again whether the Hill-Sachs is inside or outside of the glenoid tract. In this case, also, we will have the possibility of an on-track lesion and off-track lesion. Treatment strategies depending on the bipolar bone loss lesion. We consider Hill-Sachs lesions either on-track or off-track according to the criteria just described. Instead, we define the glenoid bone defect as greater or less than 25%, which appears to be the cutoff value as described in literature. When we have an on-track Hill-Sachs lesion and a bone loss of less than 25%, which corresponds to the majority of bipolar lesions, around 90%, we opt for an arthroscopic Bankart repair. When we have an on-track Hill-Sachs lesion and a bone loss of more than 25%, very rare bipolar lesions, around 5%, we opt for a Latarjet technique. In glenoid bone losses between 0 and 25%, in our opinion, there is in any case a cutoff point, which would be around 13%. With this, we would like to say that in on-track lesions with a glenoid bone loss between 0 and 13.5%, we can safely opt for an arthroscopic Bankart repair. On the other hand, we should evaluate the situation when we have on-track lesions with glenoid bone losses of more than 13.5%. In literature, a number of different techniques are described to solve these problems. Arthroscopic Bankart repair, open inferior capsular shift, and Latarjet procedure. In our experience, when arthroscopic Bankart repair is chosen in cases of major bone loss, there is a risk of having a limitation of the joint in abduction and exterior rotation because the capsulo-legamentose complex is repaired on the bone loss, and therefore the joint capsule, or rather the capsulo-legamentose complex, is put into a state of pretension. In these cases, some authors opt for an open capsular shift, while we choose the Latarjet technique. On the other hand, when we have more serious, more medialized Hill-Sachs lesions, and we are thus talking about off-track lesions and a glenoid bone loss of less than 25%, arthroscopic Bankart repair is recommended, backed up by the remplissage technique. This consists of an infraspinatus tenodesis in the Hill-Sachs lesion to transform the bone loss of the humeral head for intra-articular and extra-articular, and make it impossible for it to engage with the antero-inferior glenoid in the position of abduction and external rotation. As an alternative to this technique, in particular in throwing sports, it is possible to opt for the Latarjet procedure or the open capsular shift technique. In our experience, this combination of off-track Hill-Sachs lesion and glenoid bone loss of less than 25% involves only 5% of all recurrent antero-inferior instabilities. On the other hand, when we have a medial, therefore off-track lesion of the humeral head and a glenoid bone loss of more than 25%, we recommend the bone support technique Latarjet. In our experience, these patients account for 2%.